Otitis media with effusion. So, first we will see the anatomy of the middle ear. For the normal functioning of the ear, especially the middle ear, there are two important things. One is there are three small bones in the middle ear. It has to be intact, and the second point is the presence of air here. Where does the air come from? Normally the air comes from the nose. From the just behind the nose, which is called as the nasopharynx, there is a tube which connects the nasopharynx and the middle ear, which is called as the eustachian tube. It allows air to enter the ear. So, for the normal function of the ear, you need the intact bones as well as the presence of air. If by any reason this eustachian tube doesn't function properly, or if it is blocked by any reason, the middle ear will be devoid of air. So, in that case what happens is, the middle ear, it will go into negative pressure, and this negative pressure will suck in all the fluid from the neighboring vessels. So, you have a collection of non-purulent, no pus fluid in the middle ear, which impairs hearing. There will be hearing loss. So, why should the eustachian tube not function? It can be there is a block in the other end of the eustachian tube, that is behind the nose. The commonest cause being adenoids hypertrophy, or you can just say adenoids. If the presence of adenoid is there, it can block the eustachian tube function. That is the commonest cause. Or severe allergy or repeated infection of the nose. All this can lead to eustachian tube dysfunction. So, in fact, in short, if you summarize, because of the collection of this fluid in the middle ear, there will be hearing loss. So, this condition, otitis media with effusion, is defined as chronic inflammation, not infection. There is no infection here. There is no bacteria, there is no virus. Chronic inflammation of middle ear characterized by accumulation of non-purulent fluid behind an intact tympanic membrane. That is otitis media with effusion. Now, this is common above the age of 2 and below the age of 5, and more so it is common during the winter season. So, what is etiology? Which I have already explained. We have so many etiology, it all points to one direction, that is eustachian tube dysfunction. Now, what are the complaints? As I have already mentioned, this condition is common in children. So, the complaint comes from the mother or the parents. The complaint will be the child is not responding to the call. You call him, he doesn't turn back. Likewise, when the TV is on, he goes and stands very near the TV because he is not able to hear normally. And from the school also you have a complaint saying that he doesn't study well. Of course, yes. If he doesn't listen well, he will not respond well. So, these are the common complaints. So, when you go to the ENT doctor, he will put in a camera and he will show you the finding of the eardrum. So, you should know the normal to know the abnormal. So, this is a picture of the normal eardrum, and this is a picture of the eardrum where it is diagnosed as otitis media with effusion, where you can see a fluid level and presence of air bubbles too. So, we have a diagnosis here. So, what is the cause for this? Because there is a eustachian tube dysfunction. Maybe there is an adenoid which is enlarged, which is seen behind the nose. So, what do you need to do for that? For that, we have to put in a camera, nasal endoscopy, through the nose, behind it goes into the nasopharynx to see if there is an adenoid in the first place, followed by, if the adenoid is there, how much it is obstructing. Is it completely obstructing or is it partially obstructing? So, we have a diagnosis of the middle ear problem, and we know what is causing the middle ear problem too. So, what are the tests needed? We need 2 hearing tests and 2 X-rays. The hearing test, the first one is a pure tone audiometry, which is usually done above the age of 5. So, the child is less than the age of 5, we prefer free field audiometry. Whatever the cases, whatever the type of test is, we will assess the hearing loss. by doing the test. The second one is we have to assess what is the pressure in the middle ear, whether it is negative or we are not able to build up the pressure at all. I am coming to that. And let me show you the example of these things. So this side I have shown you the diagram for or hearing loss, that is a hearing test, and this one the tympanometry. So this is a normal one, this is abnormal one. Normal one, you see two lines going parallel and both are above 20 decibels. And the abnormal one, where it is diagnosed as otitis media with effusion, you have a gap between both the lines in the lower frequency. Now coming to tympanometry, it shows the normal tympanometry here and otitis media with effusion the other side, on the top one. So the normal one shows the graph which is A, like a mountain. It's called the type A curve. In this condition, it becomes flat because it is not able to build up the pressure. So it's called as type B curve. So that is all about hearing test. Coming to X-rays, the first one, X-ray of the postnasal space. I have shown a normal X-ray, and here is the X-ray where the adenoid is hypertrophied. In the normal X-ray, you can see the caliber of the air column is thick from below when it goes upwards behind the nose. But in the second one, if you have a look, the caliber of the air column keeps on decreasing because it is getting obstructed because of the presence of adenoids. And we have to do an X-ray of the sinuses to see if the sinus is the cause, whether it is infected and keeping on feeding the adenoids too. It can be the other way around also. So that is all about investigations. Now we have come to a diagnosis and we need to treat it now. Treatment, it can be a medical treatment or it can be surgical treatment. So medical treatment is the medical treatment is preferred if it is the child is in the early stage. Early stage in the sense, suppose the adenoid, the tissue which is behind the nose in the nasopharynx, if it is not completely obstructed, we can start with the medical treatment. If not, it is complete, if the adenoid is completely obstructing, say about 90%, and we have so many other problems also, then we can go in for surgery directly. But usually, most of the patients, they come in the early stage, and if you give a trial run, a 3 months trial run of medical treatment, 70% of the children, they improve. So let us see what are the medical treatment. One is the mainstay of treatment is going to be nasal spray. Steroid nasal spray. So this steroid nasal spray, it has to be 1 puff or 1 puff per day. I'll just demonstrate to you. So here we have a nasal spray. So this, if the age of the child is less than 12 years, it has to be 1 puff per day, say preferably in the night. I'll tell you the technique how to use this. So before using it, you have to shake it well. And when you're using the right side, the direction of the nozzle is going to be directed towards the outer canthus of the eye. This is called the outer canthus of the eye, and this is the inner canthus of the eye. So this nozzle should be directed towards the outer canthus of the eye. Likewise, when you use this side, it is to be again directed towards the outer canthus of the eye. It has to be used every day for 3 months or till the doctor tells you when to discontinue. Along with this nasal spray, we need to take other adjuvant treatments like, you can ask the child to blow balloon every day, say 10 or 15 times in the morning, likewise 10 or 15 times in the night. Or you have a little more difficult test where we ask the child to blow the balloon through the nose, keeping the other nostril closed as well as the mouth closed. Even just by trying this, the eustachian tube may open up. You can give a trial run. And in the market, there's a product called Autovent, even that may help. Simple blowing balloon is much easier than this. If the child is more than 5 years, you can advise him to take chewing gum. That is also helpful. It helps to open up the eustachian tube. If by any case, child will cause severe allergy, we need a combination of an antihistamine along with leukotriene inhibitors. Here, that tablet, you have to put in water, dispose it off, and you ask the child to drink it. So that has to be taken at least for 2 to 3 months, just like how I advised you for the nasal spray. So medical treatment goes on for 2-3 months, and every month the child comes to the hospital, comes to us, and we get a hearing test done. If after 3 months there is no improvement, it becomes an indication for surgery. Okay. Now, what are the indications for surgery? The most important single one is after 3 months, when you do after all this treatment, after 3 months, when you do a hearing test, the last third hearing test, it shows there is a significant hearing loss, as well as the tympanometry shows there's a type B curve, that it's a straight line, it becomes an indication for surgery. So what is the surgery? Surgery is bilateral myringotomy with grommet insertion with or without adenoidectomy. I'll explain to you the surgery in a single slide and I'll show you the steps also. Now, we have decided on surgery. Suppose the surgery is on Tuesday. Monday morning you get admitted. On the day of admission, the first thing we do is we take a concern from you. In that concern medical legal paper, it will be written that what procedure is going to be done on the child. Likewise, what are the complications of surgery? Please go through what we have written and please do sign, write your name and the date. Along with that, once you have done that, the doctor who is going to operate on you, on the child, he also will sign on the same page. Once the consent is over, we do a few blood tests and the X-ray, everything done with all the report which should be ready within 1.5 hours to 2 hours. You have to meet the pediatrician. Pediatrician will examine, he will give a clearance for surgery, and with this clearance paper and all the other reports, please you have to go to the anesthetist to get a clearance from the anesthetist too. So Monday from the morning till evening by 4 o'clock, all the paperwork, everything, clearance work, everything is done. Child is admitted for 2 days or 3. So Monday admission, Tuesday operation, Tuesday evening he goes home or Wednesday morning he goes home. In some centers, they do as an outpatient procedure, as a daycare procedure also, like early morning he comes and evening he goes back. They do in some centers also. So from Monday night admission, the child takes a normal dinner, preferably from home or from the hospital, and no junk food please. And from midnight 12 o'clock, nothing to be taken perorally. No fluid intake and no food also, till the staff nurse or the doctor tells you. So Tuesday morning is operation. The surgery is bilateral myringotomy with grommet insertion with or without adenoidectomy. Now, the duration for the surgery is going to be 1 hour. If it's only myringotomy and grommet, maybe much less than that. But usually it takes 2 hours inclusive of anesthesia as well as the staff nurse work. So suppose the child leaves from the ward to the operation theatre by 9 o'clock in the morning, he will come back to the room say approximately by 11 o'clock, altogether 2 hours. So the surgical steps are, so this is a eardrum picture diagram shown. We put a small incision and through that incision we put in a suction and remove all the thick fluid which is getting collected behind the tympanic membrane or the eardrum, and we put a small grommet and it is placed in position, and we will make it patent by doing suction inside also. So once the grommet is in position, the middle ear is going to get air from outside and not from the nose. So when the child comes to the room, the child will be irritable, maybe crying, try to make the child sleep. For next 4 hours or till the staff nurse or the doctor tells you, please do not give anything orally, and nothing to drink or nothing to eat, till you get the orders from them. These 4 hours, there will be IV drip which is going on, and the staff nurse may walk in and they may check the temperature and pulse rate too. After 4 hours, you will be advised to give water first, sip of water, say half a glass or less than that, and wait for 10 minutes to see whether the child is vomiting or not. If there is no vomiting, then you can start with a liquid diet on that particular day. So let it be ice cream, let it be pudding, let it be yogurt or so. So that particular day, once the diet is on and you have the staff nurse has given antibiotic as well as nasal drop, Tuesday evening, if the doctor prefers, maybe he will let you go home, or at the most on Wednesday morning. So post-operative period, immediately you may find some blood coming from the ear. and later on you can find thick fluid coming from the ear. So you have to just clean it or mop it off from outside. Do not put anything in the ear. Some centers or some doctors may prefer to put ear drops too. In that case, you need to put the ear drops 3 drops 3 times daily, 3 to 5 days. You can follow the instruction of the doctor like what he says. Now, what is the post-operative advice? So the post-operative period, the grommet or the small tube is going to stay in place for 6 months to 1 year. So you have to protect the ear for next 1 year. You should not allow water to enter. So whenever the child is going to take a head bath, you're going to put in cotton wool or cotton plug followed by application of Vaseline on top of it. Once the head bath is over, head shower is over, you can clean it and make it dry and remove the cotton. Likewise, please try to avoid swimming. If at all the child goes for swimming, you can make custom mold ear plugs so that water does not go in. And the last advice will be, whenever the child gets any upper respiratory tract infection, go to the nearby area physician and try to get the treatment for that. Because if it is not treated properly, it can spread from the nose and go to the ear, and the ear may get infected. So that's all about the surgery. So review is going to be, say, about 10 days or 2 weeks after the surgery, there's a first review. 1 month after surgery, there's a second review. 6 months after surgery, there's a third review, then followed by after 1 year. The last review after 1 year to see whether the grommet has fallen off, which goes off by itself. Most of the time, we don't have to remove it. It goes off by itself. And we'll repeat a hearing test to show you or prove that hearing has come back to normal. So that's all about this condition. And though, how can you prevent this condition? For that, if the child happens to be less than 2 years in the breastfeeding stage, maybe the technique of breastfeeding is wrong. In that case, we have to advise the mother to sit up and do the breastfeeding. Likewise, the head up position for the child too. Once the feeding is over, burping is also most important. Then, you can, if the child is more than 5 years, you can advise on chewing gum also, but possibly after that, better to gargle also. Try to avoid passive smoking and ask him to drink plenty of water. And in case of severe allergy, severe gastric reflux, these two conditions can aggravate or it can induce otitis media with effusion also. So you have to take preventive measures for these two conditions also. So this is in short about otitis media with effusion. Thank you so much.